Bueno, hola, muchísimas gracias a todos por venir, sobre todo en un día un poco especial, porque bueno, todos seréis conscientes, nos ha caído el partido de España-Portugal justo hoy, algo que no planificamos cuando se organiza este evento. Por lo que muchísimas gracias por acompañarnos así y bienvenidos. Vale, mi nombre es Diego Rosada, soy el administrador de DROS, uno de DROS, mi hermana también está por aquí, Daniela. Bueno, gracias por darnos la oportunidad de un poco presentaros las novedades que tenemos para calcular las fuentes con las nuevas fórmulas. Muchos de vosotros seguramente las conocéis, pero creo que se puede aportar mucha información nueva que nos puede servir a todos mucho. Muchísimas gracias por venir. Tenemos también el gran honor esta vez de contar con el doctor Hill, que ha tenido la amabilidad de venir y participar con nosotros en este evento. También muchísimas gracias a Haag-Streit por ayudar a hacer lo posible. Y contamos también con nombres que no necesitan mucha presentación, con la doctora Gamberri. Muchísimas gracias también por venir. La doctora Ribeiro, de Portugal, que seguramente muchos conocen. Y el doctor Correger, aquí de Barcelona, que también está aquí con nosotros presentes. Muchísimas gracias a todos. Y bueno, espero de verdad que disfruten mucho de este evento. Y sin más, y por no estirarnos mucho en el tiempo, les presento al doctor Hill.
Okay, well, my sincere thanks to Haag-Streit for putting this whole thing together, and it's wonderful to see, so many good friends here that we're going to share the evening with. Haag-Streit has asked me to do two things. One is to talk about the accuracy of lens calculations, because even the best formulas we can't talk about it without context. So what is it that we are doing right now, and where do we hope to achieve? And then also some best practices, some very basic things that allow us to do a better job. And sometimes it's the very basic things that if we ignore, they can be a problem for us. So these are my disclosures. So when each of us goes into the operating room and implants a lens, the elephant in the room is the refractive outcome. And most of the time we really don't know what the outcome is going to be until the second or third post-operative visit. And we're going to talk about a way to have a better idea what the outcome is even before surgery. So let's talk a little bit about accuracy limitations. This is your formula. This is the mathematical backbone of what most theoretical formulas are, and this is from Frederick Gauss from the first half of the 19th century. So certainly not something new. Object vergence plus lens vergence equals image vergence. Fast forward to 2018, and this is just a modern version of the vergence formula of Frederick Gauss. The problem with this approach is that the power of the lens inside the eye is relative, not absolute. In a two-lens system, a 21 diopter lens only has 21 diopters, a specific distance from the principal plane of the cornea. If that lens is 0.5 millimeters posterior, it's now a 20 diopter lens. If it's 0.5 millimeters more anterior than what the formula predicted, it's now a 22 diopter lens. So this is the fundamental part of these formulas that cause us difficulty, and a large part of the accuracy is due to something we cannot calculate. So the effective lens position can only be estimated by all calculation methods. It cannot be calculated. So we're handing ourselves over to a calculation method where we really depend on estimations. So here's an example. This one advantage of having lots of data is you can look at things in a very thoughtful and careful way, as Dr. Aaron Berry does quite frequently. This is about 17,000 cases. This is a very common plot of anterior chamber depth against axial length. And we're going to look at a schematic eye parameter, 23.5 millimeters for axial length. And I had no trouble finding more than 40 cases where the anterior chamber depth prior to surgery and the effective lens position after surgery did not correlate at all. So it's a common misconception that if somebody has a shallow anterior chamber, especially in a short eye, the lens is going to be sitting anterior. It can be actually anywhere, and Dr. Olson has helped us to understand that. So the effective lens position, the largest part of accuracy for our measurements, provided that the other parts are correct, may not correlate with our preoperative measurements. So we can solve this problem a different way. The older formulas can use regression algorithms, or you can take new formulas and solve it by regression algorithms. Here's the regression solution for this. And again, a 0.5 millimeter difference is a 1 diopter error. And you can see how great the range is for the anterior chamber depth versus axial length. So let's talk about half diopter accuracy, because this is the standard that we're now using in 2008 for our outcomes. So what's required for a half diopter accuracy? Well, at the spectacle plane, it's either plus or minus half a diopter. But at the plane of the capsular bag, it's 1.5 diopters. And this doesn't seem like a really accurate exercise, but this is what we're trying to aspire to. I'm going to share with you tonight some changes that may happen in biometry and how we approach the eye so that we can collapse this down just a little bit more. These are some well-known studies, and if we look at the half diopter accuracy from these studies, what we find is that nobody's getting it right in a really spectacular way. The Swedish registry study, one of my favorite studies, was 71% within half a diopter. The most recent Kaiser study was about 80%, but it's all clustering around one area. For the Haggis formula optimization database, I've looked at now 270,000 cases. And when we take a physician's database done by optical biometry, prior to the removal of outliers and prior to the optimization of lens constants, what we're seeing is about 72 to 74%. After we remove outliers, cases that were probably measurement errors, and optimize the lens constants, it's about 78%. We see this number over and over and over again, which means it's probably a limitation of technology. For 1 diopter outcomes, we're doing much better. So we can use the Haggis formula optimization database just because it's such a large database. And the gap that we're looking to close is about 22%. And this problem is going to be what we're going to talk about this evening. If we look at the Haggis formula optimization database a little bit more closely, less than 1% of surgeons are at 92% or better for the half diopter outcomes. 6% of surgeons are at 84%, and the vast majority, again, after removing outliers and after optimizing lens constants, are about 78%. So this is where we are right now, and this is what we're looking to improve, which is the whole purpose of migrating to something like the lens star and also using the newer calculation methods. This is 78% represented graphically. And if we're putting in multifocal lenses, I think we need to do a better job than this. So briefly, what are some of the items that can influence calculation accuracy? These are real simple things, but I think they need to be mentioned. One is the ocular surface. For those of us who develop lens calculation programs, this part of the process has probably the most noise of any measurement we have. Just even between blinks, you can get variation. Adi Abulafia in Israel has shown that if you take healthy volunteers, you measure their central corneal power using autokeratometry, bring them back 2 days later, do the exact same thing, the numbers are different. So we need to work on this quite a bit. So for keratometry, you don't want to use lots of different instruments because they may use different algorithms and measure different areas. Absolutely, we have to pay attention to the ocular surface. And a 1 diopter error at the plane of the cornea is a 1 diopter error in the spectacle plane following cataract surgery. And what we do in our office is if the Ks look a little funny, my staff goes straight to an axial curvature map, and my staff has the ability to cancel the patient's surgery if the measurements don't look right. As the carpenters say, we measure twice and we cut once. So this is a patient who was sent to me for a lens exchange. Her surgeon is a wonderful doctor. I would be happy to have him operate on me. And she wanted to read without glasses, and she was 20/20 with -1/2 sphere. You would think anybody would be delighted with that. She was very upset. Here she was when we did the initial topography. We had her sit in the waiting area just with her eyes closed for half an hour. There's the topographic map. So this is why she had a hyperopic surprise. The ocular surface can be a tremendous contributor to lens power inaccuracy. We actually requested some records from the doctor, and you can see that on the IOLmaster there were these little X's which showed that the ocular surface, had some difficulties. Measurement validation is incredibly important for what we do. Gone are the days where we just push buttons and hope for the best. So a measurement is only as good as our ability to know what it means. So Haag-Streit has a series of validation criteria, and tonight we'll have a stack of those. We have a stack that are in Spanish and also in English. In fact, Haag-Streit has now put these validation criteria in 10 different languages. So for that particular patient, the ocular surface or the reflected LED images would have been a tip-off that this patient might have had a problem, and then we would rehabilitate the ocular surface before we would move forward. And in our practice, we use a low-dose anti-inflammatory agent, perhaps punctal plugs, omega-3 fish oil, although that may or may not work, and frequent artificial tears. So these are just some of the validation criteria that Haag-Streit has made available to us. One of the things I like about the LensStar is you have access to every aspect of the measurement. So if something doesn't seem right, you can actually dig down deeper and see what the problem may be. So this is a patient where the Ks actually look pretty good. This is measurement number 3. But if you look at measurement number 2, you can see we have some issues. And this would be unchecked over to the right. It would be taken out of the measurement process so it doesn't influence the outcomes. So again, we have access to every part. We can validate the axial measurements. So here's basically how the axial measurements are represented by this instrument. It's set up to look just like an immersion A scan, which is familiar to most of us. And if we have a measurement where the calipers are in the wrong place, we can actually just move them to the right place and make sure that the measurements are correct. So we have not only access to every part of the measurement process, but we have the ability to change things, either by deleting something or moving the calipers to where they need to be. This is very powerful technology. Aside from the fact that the LensStar is a stunningly accurate device, they've also given us the flexibility to change things. And for those of you who've used Haag-Streit products, have you ever seen anything from Haag-Streit that wasn't perfect? I mean, throughout the history of the company, that's just kind of how they do things. You can dig down a little deeper. These are the anatomic landmarks for the lens. So we have the anterior capsule. Think about that. That's about 35 microns thick. We have the anterior cortex, the cortex nucleus junction, various optical interfaces within the lens itself. You can even pick up PSC plaques. The posterior cortex junction, and then the posterior lens capsule, which is 5 to 7 microns. You actually get an anatomic mark, so you can put the calipers wherever it is that you want. Optimization of lens constants is becoming more important and less important at the same time, believe it or not. With the standardization of optical biometry, the measurements are getting to be really good and almost the same, whether they're in Brisbane, Bangkok, Burbank, or Berlin. But we still need to make sure that the lens constants that we use may be correct. And I would caution you not to use the lens constants that come from manufacturers, because the lens constants that come from manufacturers are early in the regulatory process. They're meant to get the lens through the regulatory agency like the FDA in my country. And sometimes the lens constants that come from manufacturers are just not right. So here's an example. I work for Alcon actually, and this lens was my project. And interestingly, I wasn't very happy about this. They put the lens constant for this particular lens, one of the most popular lenses in the world. It's the applanation biometry lens constant. So that's the published lens constant. So you need to be very careful to make sure that the lens constants you're using are the ones that correlate with what you're doing, which is typically optical biometry. So immersion biometry is 118.9, and optical biometry is 119.0. So if you use this, you may get a hyperopic outcome. There's a new website out. It's iolcon.org. This is a doctor in Germany who's taken over Dr. Haggis's work, and it's set up just like the ULIB site. Dr. Haggis has since retired from the University of Würzburg in Germany, and this has that information plus additional lenses, and I think we'll be able to submit lenses to this site for optimization. For the last 15 years, I've been offering a free service to physicians around the world where you send me 200 to 300 cases, and I will optimize your lens constants for you. It's the Haggis optimization area on the downloads area of the website. And if you send me the cases the next day, what you'll get is a report that lists the optimized lens constants for your database, and then also a series of statistics that show where you stand in relation to the rest of the ophthalmic community, and if improvement needs to be made, some suggestions as to how to do that. For the RBF method, which we're going to talk about tonight, I've optimized lens constants for pretty much every lens that's used in the modern world. These were all databases that were submitted for optimization earlier, like for the SN60WF, we based it on 35,000 cases, so that's probably pretty accurate. But every lens that you can think of that's now being used has an optimized lens constant on this website. And lastly, I think the capsular excess probably does play a role. If the capsular excess is very large and you have like a single piece lens and there's a lot of capsular bag contraction, sometimes it can move forward, not always, but sometimes it can. And the capsular excess should be round, centered, and smaller than the optic. I use a lot of femtosecond cataract surgery, and I do a 4.8 millimeter rexus. But what if you don't have a femtosecond laser? It's easy to get fooled if the pupil's very, very large. Sometimes we have a tendency to make the rexus larger. If the pupil is small, we can make the rexus too small. This is an interesting patient. This is a man who has more money than God. And he flew his private jet to Arizona to interview me to see if I should be his doctor. I was the third ophthalmologist he had interviewed. He has megalocornea. He has some very unusual measurements, and he's had radial keratotomy. So in something like this, you might make the rexus a little bit too big because the pupil is going to be larger, even though it looks pretty normal. And what we do is we just take a 5 millimeter RK optical zone marker. We make a mark on the surface of the eye, and then we use that as the outline for the capsular excess. And I like using a cystotome. It's like utrotoforceps, except you're regrasping every 10 to 15 degrees, and you just follow the outline of the mark. It's a very inexpensive way to make a very nice capsular excess, and when you're done, it looks like this. Then half a year later, I did his other eye. So let's just finish up with some comments about formulas, where we stand with formulas and how they're used. And some of the things I'm going to say today are a little bit of a surprise, but they're based on years and years of work and observation. And also lately, some of the work of other people are coming to the same conclusions. Now, this is kind of a historical outline, and believe it or not, there's still people in Europe that are using the SRK2 formula. Unbelievable that they're still using that. This is what most of us are using, usually Virgin's formulas. We now have a very nice ray tracing formula by Thomas Olsen in Denmark, part of the Phaco Optics program, and also it's on the LensStar, and then we have artificial intelligence. Year after year, ASCRS surveys have shown that what most physicians do is they pick a formula based on axial length. And I think years past that may have been useful, but our thinking on this is changing based on some of these enormous databases that we have and the ability to look a little bit deeper and rather than just go on personal opinion. So let's just review the different formulas. This is the Holiday 1 formula. The Holiday 1 formula, in my opinion, was really one of the great gifts to ophthalmology by Jack Holiday. This was done in 1988, and it's still a very good formula. For those of you who use the ASCRS calculator for prior refractive surgery, this is the mathematical backbone for all of those cases. Now, surprisingly, the Holiday 1 formula can do very, very well for the short eye if you optimize the lens constants for these special cases. And also if you change the axial length based on the paper published by Lee Wang and Doug Koch called the Wang-Koch axial length modification, the accuracy of this is really quite good. So if you only have third generation 2 variable formulas, this is what you need. Hoffer-Q is often used for shorter eyes. Actually, it doesn't do as well as Holiday 1 does. And it can be modified for the longer eye, but most people don't use it for very, very long eyes. Interestingly, at least in the United States, SRKT is the most common formula used, but I found that mathematically it has the most problems. And Holiday 1 actually does better for database after database after database that I look at than SRKT. If you modify the axial length using the Wang-Koch axial length adjustment, you can actually do a pretty good job with this, but I think Holiday 1 still does a better job. These formulas require that you have normal anterior segment anatomy. The Haggis formula was another breakthrough where Wolfgang Haggis, instead of using a single lens constant, he turned the effective lens position into a function where the lens power was adjusted up and down globally with the A0 constant, and then the shape of the power prediction curve was changed as a function of the measured anterior chamber depth and axial length for individual patients. That can also be modified with the Wang-Koch axial length adjustment, and this does a very nice job for long eyes. The Holiday 2 formula is from 1996, and Jack Holiday also has an adjustment to the axial length that you can use for these very long eyes. But if you notice over to the left, most of these formulas require slightly different lens constants for very short eyes, and that can kind of democratize things. And the outcomes when you adjust the lens constants are really remarkably similar across all of these formulas. Thomas Olsson's formula is a ray tracing algorithm, and the version that's on the LensStar, this is its accuracy right here. This requires that all measurements be done by optical biometry, and it's difficult to optimize this because a lot of parameters have to be put in for the ray tracing algorithm that come from the manufacturer. Of all the different theoretical formulas, probably the Barrett Universal 2 formula I think is probably the best. At least that gives the best outcomes for what we've looked at, and it does very well for minus power meniscus lenses. RBF, which we're going to talk about now, is a completely different approach. It uses artificial intelligence. Version 1.0 was limited because it was only based on about 3,000 cases, and it only went from +6 to +30. In about a week and a half, version 2 will be released on the LensStar, and the range of this formula is now going to be expanded, and it does as good as Barrett, and I think even a little bit better for the very short eyes, and I'll show you why that is in a minute. So these more modern formulas allow us to deal with eyes of all anterior segment types, and I think if you're going to move to formulas from this century, you know, Olsson and Barrett and RBF would probably be the better choice. And if you had only access to one of the older formulas, I really think Holiday 1 is the better option. It actually does a better job.